Thank you very much, Tatiana, for supporting this research, and it's important for everybody together, all the societies together in Latin America. And I would like to thank everyone that is in this webinar. And we are going to talk about those reference levels. This was a research that we were doing, and now it's coming to radiation protection to optimization process. Lina and I are going to do this presentation. We have no conflict of interest. So this webinar, thank you, Marta, for she's president of Latin Safe, and she's supporting the course and also the research for Brazil, and together with Brazilian College of Radiology, and together with SLAC, we are doing a research for pediatric and adults for CT and all the other modalities after this. We would like to thank very much Dr. Madhu Deep Kaura and Dr. Lina Kaurod for helping us with this research, and all your kindness in your help. Also for the pediatric and the adults research. Dr. Manu is very kind. Thank you very much for your kindness and your very disponibility. You're very kind to us to put together the research and all your help in this optimization process and recommendation to all the sites that participate on this. Renato Dimenstein is going to get into this webinar to discuss, and Tatiana also is going to participate in the discussion section. So we are going to focus on the DRL. In Brazil, we say níveis de referência diagnóstico, so NRD campaign in Brazil and Latin America. We did a website for data collection, and also Lina is going to talk about the preliminary results analysis in Brazil and recommendations. Eu vou falar em português agora para a gente ter os dois públicos. Então, muito obrigada a todos pela participação e nesse webinar, e um especial agradecimento ao Dr. Kaura e Lina, a também a Marta e Tatiana por nos apoiarem no projeto, tanto no Brasil como na América Latina. É muito importante para os nossos pacientes. Esse projeto e essa campanha a gente fez no Congresso Brasileiro de Radiologia, no Congresso Brasileiro, tanto para o Brasil como para a América Latina, e a nossa motivação foi a ação do Bond Call for Action, que a segunda ação é a implementação de otimização de processos de otimização de radiação e dos exames radiológicos, né, com segurança do paciente, em que o nível de referência é citado para todos os procedimentos, principalmente para crianças. Então, é ter a dose correta para o paciente correto. E também o estabelecimento e fortalecimento de proteção radiológica na educação e treinamento dos profissionais. Então, esses vão ser as duas ações do Bond Call for Action que nos motivaram a fazer esse projeto. O projeto iniciou com um projeto piloto no Brasil para adultos e se estendeu para um projeto nacional e na América Latina, que desenvolvemos um site. E agora estamos numa fase de otimização e educação com a ajuda do Paula e da Lina da Universidade de Harvard. Então, o importante é que fizemos os níveis de referência baseados em indicações clínicas para tomografia, e também a nossa referência foi a publicação 135 da Comissão Internacional de Proteção Radiológica. Todos esses parceiros, né, nos ajudaram a fazer esse projeto e ação conjunta para esse desafio. O projeto inicial teve o apoio do Instituto de Física da USP, do Dr. Paulo Costa, que é o projeto meu do doutorado. Tivemos o envolvimento de 7 estados, 12 hospitais, com coleta de dados de aproximadamente 4.500 dados. Fizemos a análise dos dados, temos um processo de publicação. O projeto se estendeu para o Brasil, né, que é um projeto nacional que vai se estender para tomografia, raio-x e mamografia, adulto e pediátrico, do ano de 2022 a 2023, e já temos 12 estados que já se aderiram, e a gente espera que vocês, e quem estiver assistindo, aderam ao projeto, e estamos à disposição para que a gente possa trabalhar junto nesse desafio. Na América Latina, com o apoio do SLAC e do Latin Safe, com o apoio da Lina Cavidade, Carlos Uga e a Tatiana Fazecas, doutora Marta. Então, foi com a organização da doutora Lina, está sendo coletado dados de tomografia, de cérebro, tórax e abdômen, com 10 países já envolvidos. Estamos numa fase na análise de dados, com orientação do Dr. Manu, para orientação de publicação desses dados, com orientação de todos os sítios e hospitais envolvidos, com, inclusive, recomendações para os protocolos. Então, a metodologia que a gente usou para todos esses projetos é determinar um time para a coleta de dados, avaliação dos equipamentos, a determinação da coleta. Agora a gente tem um site para coleta, inicialmente foi por umas planilhas, que então é possível se fazer até por uma planilha de Excel, apesar de ser mais trabalhoso, baseado em indicação clínica. Determinamos inicialmente um paciente padrão, mas fizemos estratificado para paciente standard e também paciente sobrepeso e obeso, de acordo com a massa corpórea, e agora pediátrico, de acordo com a idade e com o peso do paciente, com avaliação posterior de qualidade, seguindo, então, a metodologia que a Alina vai comentar a seguir sobre as definições e conceitos do nível de referência diagnóstico. Gostaria de apresentar para vocês o site que nós desenvolvemos com o Colégio Brasileiro e que foi a seguir passado para o Latin Safe. Esse site teve o apoio da Escola Superior de Tecnologia e Saúde, do Dr. Graciano. Então, ele foi baseado num projeto de Portugal, e que vai ser para radiologia geral, tomografia e mamografia. Então, a coleta já está se iniciando pelo site. Tem avaliação dos equipamentos, o modelo do equipamento, a marca, as tecnologias, né, a data de calibração e o fabricante, isso igual ao modelo do Dr. Graciano em Portugal. E o site, ele chama nrdbrasil.com.br, podem se inscrever, e o site da América Latina é nrdamericalatina.com.br, que estamos finalizando ainda essa semana. Então, são baseados em indicações clínicas, por exemplo, para crânio, dor de cabeça, trauma, isquemia, para coluna cervical, sinusite e trauma de coluna, tórax, pneumonia, TEP, e na época com Covid, né? Para abdômen, cálculo renal, apendicite, e a parte de estadiamento oncológico. Então, esse site tem, para cada indicação clínica, as características técnicas, em que se podemos coletar os dados do equipamento, altura e peso do paciente, a presença ou não de reconstrução iterativa, modulação de corrente e as grandezas dosimétricas. Então, vai possibilitar a gente ter uma análise e fazer recomendações. A gente fez uma breve pesquisa, isso quando teve um webinar com o Dr. Graciano sobre dose de referência diagnóstica, e que a gente observou que as instituições, cerca de 60 instituições responderam, tanto no Brasil, algumas na América Latina, instituições que tinham controle de qualidade, geralmente possuíam também níveis de referência diagnóstico para algumas modalidades, mas a gente observa que tem uma oportunidade aqui, então, menos de 50% das instituições possuíam nível de referência diagnóstico. Então, uma oportunidade de a gente poder treinar os profissionais e fazer maior segurança para os nossos pacientes. Da mesma forma, recursos de reconstrução de corrente, nem todos possuíam alguns recursos, ou a maioria referia modulação de corrente, ou um pouco mais de um terço ter reconstrução iterativa. Então, uma oportunidade também de treinar os profissionais a usar a sua tecnologia para reduzir e otimizar a dose. E um ponto positivo nas respostas foi que a maioria, cerca de mais de 80%, tinham protocolos específicos para pediatria, mas a gente está agora analisando com o Dr. Kaur aqui e com o grupo do SLAP e do Latin Safe, que a gente pode ainda otimizar essas doses para as crianças. Em comum parceria com a Comissão Internacional de Proteção Radiológica, né, saiu uma nova publicação em um grupo, um task group sobre as metodologias, né, de treinamento. Então, isso também vão ser aplicadas essas metodologias. Esse é o curso que a Marta comentou, que vai ser o primeiro módulo, né, com a participação de uma equipe multiprofissional, e que todos estão convidados. Agora a doutora Lina vai dar andamento à apresentação.
Thank you, Monica, for the introduction and for inviting us today. Hello, everyone. I'm Lina Karut, Research Fellow at Mass General Hospital, Harvard Medical School. And as per Dr. Monica's talk, I'll be presenting the results of the pilot study that aimed to establish a national diagnostic reference level for adult computed tomography in Brazil. So, what is diagnostic reference level? A diagnostic reference level is a specified radiation dose for a given imaging study that is not expected to be exceeded. If a radiation dose does exceed the diagnostic reference level for a particular study, this should prompt an investigation into radiographic technique or equipment performance. Diagnostic reference level values vary based on local, regional, and national data. They are typically set as the 75th percentile of a distribution of a radiation dose. So it can be a 75th for CDI volume or DL2. So the results of our study included 13 institutions from 8 states across Brazil, from 9 different protocols, a total of 4,757 patients. We have that 57.4% of our population were females and 42% were males. The mean age was 50 years plus or minus 18 years. And in terms of body habitus, interestingly, more than 65% of our population was obese or overweight. We have that 1.2 were underweight, 33.1% were normal, 41.5% were overweight, and 24% were obese.
Yeah, so this basically shows that almost 2/3 of the population is actually either overweight or obese. And, that has relationship on the dose that larger patients typically need higher radiation dose. And this is something that, when we go through the doses for Brazil, we will have to compare. But the good thing is that, well, I don't know if it's a good thing or a bad thing, but the thing is that most of the world is going this way. Whether it's a developed world or an underdeveloped world, we are seeing that almost 60 to 70% of the people are either overweight or obese. So that is something that we have to keep in mind when we look at the doses. Lina, you can continue.
Okay. So in this slide, I will provide the national diagnostic reference level for different protocols in Brazil. So for HET-CT, the level was 45 milligrays, which fortunately was lower than the UK and US level, which was 60 and 56. For HCTA, the level was 26 milligrays. We did not find a UK and US level, diagnostic reference level, but according to experience in the domain, 26 milligrays is acceptable for HCTA. For chest CT, the level was 11, and fortunately, as HCT, it was lower than UK and US levels. For PE protocol, unfortunately, the level was 15, and it was higher than the international values, US and UK. For chest, abdomen, and pelvis, the level was, just a minute, I can see. The level was 13, and it was lower than the US level, which is also good. Here for the PE protocol, this shows that there's major scope for improvement, need of improvement. For abdomen CT, the level was 12, and it was lower than the US and UK levels. For kidney stone CT protocol, it was 13, and it was higher than US level that varies between 10 and 12 milligrays. For paranasal sinus, it was 16 milligrays, it was 19 milligrays, and although we don't have also a national diagnostic reference level for UK and US, according to experience in the domain, the level is high borderline. And for cervical spine CT, the level was 23, and it was lower than the US level and higher than UK level.
Yeah, so although the chest levels, as you can see, is just under the US and UK level, there is, a general consensus sort of that the chest CT-DI volume should be typically less than 10 milligray or 2 digits. So they should be in single values. The other thing to remember is that the chest doses should be really at least 30 to 40% lower than the abdominal dose values. Here you can see the chest doses are almost identical to the abdomen doses. In fact, this is a very easy test that if in your site, you see that the chest CT doses of the same patient are almost the same as the abdomen doses, or they are higher, that means something is wrong. The protocols are not optimized. So this actually tells me that those protocols for chest need optimization, right? And the other thing is the kidney stone in the abdomen CT. So as you can see, there is hardly any difference between the two. There is also a consensus that the abdomen CT doses, be higher than the kidney stone doses. Why? Because kidney stone doses, kidney stones can be seen very easily, and they are not missed even when the images are noisy or have too low of a dose. And typically speaking, the kidney stone doses should be about 30 to 50% lower than what you would have for your routine abdomen CT. Right? And it should not be higher than the abdomen CT doses. And likewise, there are many studies, as Lena pointed out, on the paranasal sinuses where, people have done these scans between 5 to 10 milligray instead of 19 milligray. And a little bit of that depends on the scanner and the technology that you have. But even with the older scanners, it's possible to go lower than 19 milligray. The good thing is that it's far below the head CT doses. So that's the great thing, right? But the scope for improvement is that it can go lower. Yeah, Lena, you can continue.
Sure. So now in the following slides, I will show how the radiation levels varied for each protocol in terms of the 13 participating sites. We have the two lines here, the dotted lines. Yellow represents a US level and green represents a UK National Diagnostic Reference level. We have that the majority of sites for head CT had a lower radiation level than the international levels. We have that one site was borderline and two sites had a higher level. As we can see, radiation varied from as low as 26 to as high as 78, showing major variations across sites.
Yeah, so this needs clapping, I think overall, most of the sites in Brazil are doing very well in protecting what matters the most, the gray cells, right? So the head CTs are being done very well. There are some sites that we need to, and we will look into, for example, the sites that are either 60 or higher, and we will have to either, look at how they are doing the head CT, whether this is helical or this is axial acquisition, whether they are using proper tube current. And one of the problem that we have noticed is people using very slow gantry rotation time, like 2 seconds or even longer. Those actually cause motion artifacts are really not necessary. So those are some of the things that we intend to look at to help these very few sites to actually come within the range of what is an internationally acceptable level. Thank you, Lena. Continue.
Sure. For head CTA, the levels we have 4 institution provided data, and it varied between 6 to 32 milligrays.
Yeah, so there are some papers, although one thing that is good about this is that at least the head CT angiography doses are lower than the head CT. That's great. Now, the next question comes is, why should they be lower? Well, the reason is that when you're looking at the brain, you're looking at gray and white matter difference. If you have very low dose image, the noise will not let you evaluate whether the gray and white matter difference is normal or not. So you can miss subtle things. But when you're doing CT angiography, you're looking at high contrast structures. Contrast structures meaning the vessels. And those can and should be seen at higher noise at lower radiation dose. And that's why I think if you look at the literature too, based on what kind of scanner you have, there are studies that have shown that you can be pretty much half of what value is shown here in red, for example 32, even several times lower than 26.2. Now if you want to go in single digits like the 6 milligray site, you really need to have iterative reconstruction. You really need to have lower KV and higher MA combination, higher end scanner. But one can actually easily go below 20 milligray, kind of a cutoff that I use for a good head CT exam. Okay, Lina, you can continue.
For paranasal sinus, also the radiation levels varied between as low as 2 to as high as 32. Yeah.
So as you can see here are some of the values from US and the European Union, right? They are, to my knowledge, a little bit on the higher side. The newer machines actually, you can easily go below 10 milligray, and you can actually see that 4 of the sites do actually operate at 10 or less than 10 milligray for CTDI volume. So there is certainly a room to reduce the tube current, a room to tweak the scan parameters so that the doses for this screening exam is actually lower. The other point is that, the paranasal sinuses are divided into 2 groups. One is for screening purposes before they do, functional endoscopic sinus surgery. And the other is when you're looking for a mass or a cancer in the nasopharyngeal or paranasal sinus region, you're going to give contrast. So those are 2 separate things. When we talk about paranasal sinuses, we mean those patients who are undergoing screening surgery before their endoscopic procedure, right? So therefore, those exams should be done at lower dose. But if the patient has cancer or you're looking for doing local staging, all of these doses are acceptable. Proceed, Lina.
Sure. For cervical spine CT, we have the UK level is 21 and the US level is 28. We have that 5 institutions had radiation levels lower than the international levels and 2 were borderline.
Yeah, so here they're not doing too bad. I think this is very good that they have optimized the cervical spine CT very nicely. Good work.
Okay. For chest CT, we have that the UK level was 12 and US level was 13. The majority of sites had radiation levels lower than the international levels. Only 1 was borderline and 2 sites had higher radiation levels.
Yeah, one of the issues that we spotted with the doses were that the use of low KV or low tube potential, sites tended to use less of that, and that can lead to very high dose. The second thing is that, one rule of thumb for the chest CT dose optimization is that you need to be in a single digit for your median doses. Even the median doses, we are talking about 75th percentile, but even for the median doses, you need to be in the single digits of CTDI. And anybody can use that formula to tweak these parameters to make sure that unless the patient is really big, what I mean big is that the patient is sort of weighs 100 kilogram or something like that, you really do not need to go above that 10 milligray threshold. So, even I don't like to see even the 10 there. And, the US and the UK machines, if you look at the higher end scanners, typically the chest doses have come to 3 to 5 or 6 milligray. So 3 to 6 milligray is the sweet spot. So anything over is either because there is old technology or there is less optimization. But this can be very easily improved, and we intend to improve on this. Go ahead.
For PECT, we have that the UK level is 13 and US level is 14. 3 institutions had lower radiations than the international level, and 1 institution was borderline. And 2, they had higher radiation, 15 and 21.
Yeah. Again, you can see that the European Union data, actually for pulmonary embolism CT, you can see that the DRL is 5.5. So if you look at that DRL, all of these doses are higher. And one of the reasons for all of these doses being higher is the tube potential being too high. In fact, there is a very simple rule of thumb that one can use, is that if the patient is less than 80 kilogram, you should use 100 kV. If the patient is less than 50 kilogram, use 80 kV, right? And that does help in a big way to reduce the radiation dose. The other thing is that although people have automatic kV selection technique in many of the scanners in Brazil, if you do not set the right reference kV, the technology will not realize what you're doing and will end up using higher kV and give higher radiation dose. So therefore, having technology doesn't really mean that the results will be favorable, but having the right technology, as you do have, means that you can very easily tweak a couple of things, and the next day your doses will be fixed. Go ahead, Lena.
For abdomen CT, the UK level was 15 and US level was 16. Most institutions, they had a lower radiation level. 1 institution was borderline, 16, and we have that another institution had a higher level of 25.
Yeah, so one of the problem with the abdomen CT is the number of phases that people acquire. And unfortunately, worldwide, there is this trend of acquiring too many phases, doing non-contrast for every abdominal CT, and then doing arterial phase for every abdominal CT, portal venous phase, doing delayed phases throughout the entire abdomen. Now, those numbers are not reflected here because the number of phases affect the total dose length product more than it affects the CTDI volume. So I think the optimization of the abdomen CT will have to start from reducing the number of phases. For example, in our institution, about 10% of the abdominal CTs have 2 phases or 3 phases. So, and the only place where you use non-contrast is when you're looking for kidney stone, you're looking for hematuria, when you're looking for something in the abdomen, like a ruptured aorta or things like that. So very selective indication is, or you're looking for adrenal mass protocol. And these should not represent majority of the abdominal CT. So one is reducing the number of phases. That's going to be very, very important. And the second thing is, of course, using the iterative reconstruction that people have on their scanners so that they can reduce the tube current or tube potential and do a good job in terms of reducing the CTDI volume. Go ahead, Lena.
For chest, abdomen, and pelvis, the US level was 15. Most institutions also had the lower radiation level. 1 was borderline, and 1 had a higher level of 24. Okay. For kidney stone CT protocol, we have that the US level varies between 10 and 12. Most institutions had a lower radiation level. However, 3 were borderline and 4 had a higher radiation level that varied between 13 to 25.
Yeah, again, I think kidney stone doses for at least up until the patient is really obese should be in single digits in terms of CTDI volume. Anything more is actually excessive. right? You can see the European levels also. 9.5 is the DRL, and 6.9 or around 7 is the median dose. So compared to that, most sites, well, at least half the sites would need some help reducing the dose. And the 25 milligray is really an outlier, which we need to investigate more thoroughly as to why that is happening. Go ahead, Lena.
Okay, so this slide, it shows a bar graph showing the variation of CTDI volume per clinical indication and per patient age. So we can see that there's significant difference in radiation levels in terms of patient age in multiple protocols, as in abdomen CT for renal calculus, angio CT for brain, chest, abdomen, pelvis for oncological staging, chest CT for COVID, chest CT for pneumonia, and head CT for headache.
Yeah, so typically speaking, we don't see an increase in the head size with the change, or basically, with the age or things like that. So, however, there may be underlying variations in the patient's size. In other words, what we need to investigate is the size of the patient. Does it really vary with the age of the patient? And is that what is causing the variations in the radiation dose, kind of an incidental effect? But one of the reasons to put this slide up there is that, very few sites and countries actually change the dose to make sure that the younger people get lower dose. And it's often accidental that the younger people get lower dose or higher dose rather than intentional kind of reduction. And this is something that we need to target as we go more and more into this, is do we take care of the younger people, as well as we take care of the older people. In the older people, if they are 60, 70, 80-year-old, there is really no reason to use low-dose protocol, because these patients do need a better quality exam because their disease tends to be more complex. They often have cancer. The benign indications are less frequent. So therefore, the compromise in the image quality should be avoided in at least the older people as compared to younger people. Go ahead, Lena.
So this pie graph shows a variation in CTDI volume per clinical indication and patient body habitus. As you can see also that we can see here that there's an increase in radiation levels with the increase in body habitus, which is actually expected. This is true, this increase was significant, especially in abdomen protocols and chest protocols, and also as expected, it was not significant in head protocols.
Yeah, because the head doesn't change with the body size, so therefore you wouldn't change it. But I think this indicates that people are using automatic exposure control or tube current modulation. Great. And it also suggests that there is a certain level of technology and technological awareness in Brazil, in terms of making sure that smaller patients actually get low radiation dose. So this is actually a very good sign.
So this bar graph shows also the variation of CTDI volume per clinical indication and CT number of phases. As we can see, different protocols and clinical indications had different number of phases. Mainly the head protocols had 1 or 2 phases. Here we can see that chest protocols had multiple phases, and this is a place that we have to work to improve in the future, as most of chest should be done with a single phase. And for abdomen CT, we can see multiple phases. And there was significant difference in the radiation levels in terms of the number of phases, and as radiation level increased with the number of phases.
Yeah, so ideally, when we talk about multiple phase exam, we should be displaying dose length product and not CTDI volume, because you would see how the radiation dose creeps up as you increase the number of phases. It just goes up linearly, right? One of the things that is important to know is that when we're doing, for many of the exams for which we do 2 or 3 phases, one should not just duplicate the entire series. For example, if we are doing, let's say, liver protocol, where we are doing non-contrast arterial portal venous delayed. So first of all, we don't do non-contrast for liver anymore, except for very, very few cases where there happens to be a liver donor or a, kind of a transplant evaluation. So there is no non-contrast for us, for liver. Second, the arterial phase is only through the upper abdomen. There is no need to go to the whole abdomen and distribute the dose to the pelvis, right? And the delayed phase is only going through the liver, or in many cases, if you have a liver lesion that you're going to assess, you just go through the lesion. This way, even if you scan 4 times, you are not going to make the dose go 4 times higher, okay? And that is the way to deal with multi-phase protocol. Look at what you do with your dose length product, look at what you do with your scan length, and then also remove some of the redundant phases. In fact, none of our chest CT protocols have 2-phase acquisition. We do not do non-contrast exam. There is a lot of misconception. Oh, how are you going to see ground glass opacities on a post-contrast direct? It's not a problem. You can see them. It just requires experience and just getting used to it, right? How are you going to see calcification? Again, we do about 150 chest CTs a day, and we report calcifications in 50 of the 60 contrast studies that we may be doing every day. So it's very frequent and something that can be easily learned, and therefore a chest CT is either a non-contrast or a post-contrast, and it is never both the phases. So that's why Lena pointed out that that needs to change, and that's something that we need to work on. Go ahead, Lena.
Sure. And this slide shows the variation of CDI volume per clinical indication and KV selection. You can see that there is difference in radiation levels in terms if automatic KV was used, yes or no, in abdomen CT for appendicitis, abdomen CT for renal calculus, in chest, abdomen, pelvis for oncological staging, chest CT for COVID, head CT, brain trauma, and paranasal sinus CT, sinusitis.
Yeah, so however, in 5 of the 13 protocols, the doses actually ended up higher with auto KV than with fixed KV. So that means that either the reference KV that was suggested was not appropriate, because the studies actually have shown that when you use this automatic KV selection technique, the scanner does use lower radiation dose. Right? Now, there is a variation depending on whether you have a GE scanner versus a Siemens scanner or a Canon scanner. The threshold for selecting lower KV with these techniques vary. So some of it is a function of what type of scanner you have. Some scanners do a very good job. Others are very conservative. They do not reduce the KV, which means if you set up a high KV, for example, the reference KV for the chest should be 100 and not 120. The abdominal KV is 120 when you're doing portal venous phase or delayed. For all arterial study, the reference KV should be 100 kV. If you set it up at 120, you will force the scanner to use higher KV and end up using higher dose with a better technique. So that's something that, again, we need to look at as to why, despite having the technology, the doses are not showing the trend that we expect. Go ahead, Lena.
Sure. And lastly, this paragraph shows that the variation in CTDI volume per clinical indication and iterative reconstruction. There was significant difference in abdomen CT for appendicitis, cervical spine CT for trauma, chest, abdomen, pelvis CT for oncological staging, chest CT for oncological staging, chest CT for pneumonia, head CT, brain trauma, and head CT for headache, and head CT for stroke, and paranasal sinusitis.
This is a really disturbing slide, perhaps the most disturbing slide of everything that Dr. Lena has presented. And the reason is that this should never happen. There are at least 500 studies, if not more, that have shown that when you have iterative reconstruction technique, your doses need to be lower than the filtered back or without the iterative reconstruction technique. This suggests that the scan protocols need a very big change. And, these scanners are supposed to be more expensive. Often people have to pay extra to get iterative reconstruction technique. And the reason they pay extra and the scanners are more expensive is because these techniques help reduce the noise, help you reduce the radiation dose. But this actually shows you just having a great scanner or having a technique is no guarantee. the radiations will go down, right? They can actually go up, which is unfortunate, but this is something that we can easily fix, right? And we will have to fix it because this is something that cannot go on. Go ahead, Lina.
Sure. Here, Dr. Kara will provide some input on the scanners and radiation doses.
So it is true that the newer scanners, the upgraded scanners, are more dose efficient in terms of using more of the X-rays that come out of the X-ray tube. They also provide better image quality with iterative reconstruction or deep learning reconstruction techniques. There are multiple studies that have shown that with the iterative reconstruction, you can reduce the dose by 30 to 50% as compared to without, right? So that's why I was very disturbed with the last slide that Dr. Lina presented. The newer scanners also have capability of automatically centering the patient, automatically positioning the patient, automatically doing the acquisition where the contrast tracking has to be done, and automatically deciding how long the patient has to be scanned over. So these technologies are very exciting, expensive at the moment and limited to some scanners, but they do help you. But the question, but I think it is important to realize that just having the technology doesn't make our job easy, right? And that's where the radiologist, the physicist, and the technologist role come in terms of using the technology properly. And that is very important message, as we have learned that the two techniques that help you reduce the dose, iterative reconstruction and automatic KV selection technique, they need to be optimized so that we can get the maximum benefit out of them. Go ahead, Lina.
So as a conclusion, as expected for any country, there are large variations in radiation doses across different institutions in Brazil. The overall radiation doses across Brazil are below the diagnostic reference level for US and Europe, which is really good. However, there are still improvements needed on several fronts, especially on kidney stone CT protocol, controlling use of multiphase for abdomen CT, eliminating use of multiphase for chest CT, and clinical indication-based radiation dosing protocols. Thank you.